thank you, everybody. Thanks for having me. So my name is Lisa McDermott, and I am, as Diane had said there, one of the advanced clinical practitioners at University Hospital at Monkland. So that was a great presentation. We could certainly use Diane in the ED. So I'm just going to chat through, if it's okay, about how I got into advanced practice and what how my role came about. So traditionally, there's limited pharmacy services within the ED. I don't know if anyone's ever worked in an ED or worked with a pharmacist, but certainly in Lanarkshire there was no pharmacists in the ED. So there was funded together to get to get some pharmacy input into the ED. So this was more of a traditional role that it started out. We were trying to do sort of medicines reconciliation for the patients in ED, prescribing, reviewing patients' medication. We also were making sure that there was a timely supply of medications, big things like stock of the recess cupboard, etc. And I also undertook a teaching and advisory sort of role within the department. Over the sort of coming months, we had sat down with one of the consultants who was my mentor at the time, and what we looked at, we kind of explored, was there anything else that we could do to give a better sort of a dual workforce almost within the ED. So I had worked with hospital at home previously and undertaken some advanced practice or sort of patients examination courses. So we then explored the sort of possibility for myself to work along the advanced clinical practitioners within our department. So we have nurses and paramedics within this role. So for me to do this, we started to look at, For me to do this, we tried to see whether there was any information out there about pharmacists in these sort of roles. So Health Education in England had commissioned a report in 2013 about pharmacists in the ED, and this was then backed up by further work in the end paper study. So in the pharmacists in the ED study, it asked 3 questions. So what I'm just going to do, I'm just going to introduce my role and how it came about and how we developed, and just hopefully give you a wee bit of insight of if you could have a sort of pharmacist within your group. So the pharmacists in the ED study had 3 questions. So let's just explore that. So what extra training is required? So as you know, pharmacists are sticklers for the rules. They like the rules, and they like to be a kind of framework to work under. So we are very sort of academic almost. We like to do that, but our clinical skills really aren't maybe weren't up to speed at that point. So for us as an ACP team, we need to all be there at the start line, just like this picture, being able to undertake patient examination and do it in a way that we are competent with our other members of the team. So how did we do that? So I don't know if you've ever worked with a pharmacist before, but this slide just kind of demonstrates our academic sort of footprint. So we have a four-year master's undergraduate degree. We then go on to do a 12-month placement within your required field, whether that be community pharmacy, hospital pharmacy. This is then backed up with a 2-year rotational programme. Now this rotation is a really basis, and this is your foundation of working. So this is when you get to do sort of medicine, surgical, and then your specialties. So at the end of that, you come out with a good knowledge of prescribing in different patient groups. We then are encouraged to go on to do a postgraduate sort of master's in clinical pharmacy, which is sort of the old term because I'm a wee bit older. It's now advanced clinical practice, and then your prescribing qualifications. So when I came on to work in ED, I had this sort of clinical portfolio that was really quite well, but actually my clinical skills were lacking. So we looked at it and we thought, what do we need to do? So if you are considering a pharmacist, this may be where they're coming into this sort of advanced role. So I had to quickly increase my clinical skills and my hands-on experience with patients. So I undertook some qualifications in urgent care and minor injuries qualification, and also a very good course for pharmacists like myself who are trying to sort of top up our academic achievements and be able to work on the floor. So this is called Advanced Specialist Training in Emergency Medicine from Manchester University. Now this one has modules on emergency care, so it's all to do with the acute presentations, and it also has advanced clinical skills in it as well. So I undertook this just to bring myself up to the level of the other my nursing and my paramedic colleagues that were already on the team. So we are quite lucky as pharmacists, a pharmacist group, we work under the Royal College of Emergency Medicine clinical portfolio. So we're wanting to credential as a EMACP. So this is just taken from the RChem website. So obviously when you're starting any sort of advanced practice, you have to have a good foundation of clinical experience before you can develop at any level. So as it says here, you have to be 5 years post registration and minimum of 3 years emergency care emergency care experience. So I am 20 years post registration, and I've been working in the ED for about 5 years now. Now I have served my time, as I said, the first 4 years of me being there was doing all those blue sections to try and get my skills up to par and be able to work autonomously and safely on the floor. So what can pharmacists contribute to the team and I'm talking about the ED team in my role. So I think we can contribute quite a lot. So firstly, my funding is 50% from pharmacy and 50% from the sort of medical directorate. So this is really good. We have got buy-in from both sides, and we have got a good strong sort of backing for this. So that's one thing. If we can buy in from both teams, it works really well. So my week would consist of 80% clinical. And where do we start as a pharmacist? We start where you are most comfortable. So I came from a care of the elderly acute admissions unit background. So I started in majors. Now initially I went for your overdoses, your polypharmacy, just to get into the way of it. Now, as I say, this has taken 3 years to get to this point. It's very much mentored by pharmacists. You've got direct observation of practice within that. So we're working under sort of strict educational sort of framework. So I started in the majors, and then once I was comfortable with that, went into minor injuries, and now I'm able to go to resus, but obviously with sort of guidance from my senior sort of registrars or senior ACP team and our consultants. So at the end of the day, what we want is a team that, although they're multidisciplinary, we are able to work at the same sort of level across the board within the department and see the same types of patients. Now, where we bring our value is really in our non-clinical time, I think, as well, or this is what our wee golden nuggets bring in. So non-clinical time, so we've got 20% non-clinical, and as I say, I lead on all things medicine. So I've put an array of slides up there that show what sort of work I've done. So things to do with PGDs, guidelines, QI projects. We also did 5 minutes of pharmacy, which is, we don't have a lot of time in the ED, so it's 5 minutes of bite-sized teaching every week on medicine related issues for the nursing staff. So this is really where you bring your value, and I think it really shows as a multidisciplinary team what you can add within that advanced practice team. So as I say, this is where it is advantageous to have different disciplines within your team. So to what extent can I clinically manage a patient in the ED? I think I can manage them pretty well, and over the past five years this has developed. So I think I am now on par. Resus cases, obviously we do it under the direction of a consultant, but I think with everything, with learning, with education, we all can get there. So the benefits of having a pharmacist on your team, what would that be? So if we think about the ED and what walks through the door, pharmacology is in part of most presentations within the ED, whether that be people taking too many drugs, as in overdoses, your polypharmacy patients, or your acute prescribing. We are there as a medicine specialist, I suppose, and we can give good advice to the team. We also bring a bit of safety, medicine safety, to prescribing as well. So as I said, the multidisciplinary approach really optimises patient management. When we see a patient, we have different experiences and different knowledge. So when that comes together, it really optimises patient care. As I said, the non-clinical time is really where the benefits can excel themselves for each, whether you're for a physio or a paramedic or a nurse or a pharmacist. As I say, we all bring a lot of good things to our NCT. And again, we want to build this sort of flexible workforce, especially in these times. So it has its benefits, but it's also been quite challenging as well. So there will be some days that you feel absolutely useless, in this advance. You go from being a specialist pharmacist back down to, you're starting to learn again. So you can feel a bit of imposter syndrome. People aren't being intentionally obstructive, but sometimes it is very difficult to get things moving. Like, I had problems with my x-ray, entitlement, etc. And some people just won't agree. But see, when you find your people, it works really well. So my advice is just find your people, find your team, and it will work really well. So just lastly, I've just asked our consultants, because you know what consultants are like. They never lie. So just to get a wee bit of feedback about the benefit of a pharmacist advanced practitioner would be on the team. And as I say, this is what they said. So I'll leave that with you. But thank you so much for letting me speak to you today.